Chapter 32, Part 1, Soft Tissue Trauma. Let's get into it. So when we talk about some skin injuries, let's talk about a quick introduction. So you'll just dropping back a little bit, A and P. Remember, the skin is the largest organ of the human body, so it kind of serves as interface between the body and the outside world. There's a lot of common injuries within this that you see that are frequent. So within these soft tissue injuries. Now, just by a quick definition, of a wound, we're talking about any injury to the soft tissues. And then most of these soft tissue injuries, they're generally considered low priority injuries unless they compromise the airway. So, we're talking about any injury that affects the breathing. That should be addressed immediately, which we should be addressing in our primary survey anyways. And then also massive bleeding. So in the event there's significant blood loss, that really escalates the priority of treatment. Now, we want to always conduct a systematic search for other injuries or life-threatening conditions before treating soft tissue trauma injuries. And then a really big point is to not allow dramatic soft tissue injuries to distract us from performing a thorough primary survey. So imagine, you go up on a call on the highway or wherever, and your patient has a large avulsion to their head, or they have a really bad eye injury or something. That can be quite distracting. And the thing to think about is we do not want that to affect us from doing a good primary survey. Typically, people do not die from large avulsions. I say typically. However, they do die from airway mismanagement and breathing issues and all of that. So incidence, mortality, and morbidity. So soft tissue injury can be injured by, we've got blunt injuries, penetrating injuries, burns. So when we say blunt injury, remember we're talking about that impact or force without breaking the skin. And then penetrating injury, that obviously results from objects that pierce the skin as well as the underlying tissues. And then burns is damage caused by heat, chemicals, or electricity. Now, soft tissue trauma is the leading form of injuries encountered in medical practice. Lots and lots of soft tissue trauma. And then there's wound care issues within this as well. It's one of the most frequently performed procedures in ED across the United States, so emergency departments across the United States. And then most soft tissue injuries, they really require only basic interventions for treatment. Still continuing on with the morbidity and mortality and morbidity. So death from soft tissue injuries, pretty uncommon unless it's related to hemorrhage, so that uncontrolled bleeding that can lead to shock and potentially death, as well as infection. However, that's not something that typically we deal with per se, is soft tissue infections. However, those open wounds can result in local or systemic infections. Those infections can be life or limb threatening, especially with patients with pre-existing medical conditions. So hopefully you're thinking kind of diabetes, and just really circulation issues can cause a lot of that stuff. So the whole prevention of soft tissue injuries, people wearing gloves when they're working with abrasive materials, safety devices. So when they're working with machinery, using safety devices to really minimize the risk. And then obviously teaching some children, or not some, but all children, to avoid using sharp objects to prevent injuries as well. Now, anatomy and physiology of the skin. I hate to break it to you, but there's a little bit of A and P in here. So the skin, or remember the integumentary system, is a complex organ that plays a crucial role in maintaining homeostasis. And that's a big thing, is that homeostasis, keeping everything kind of where the body needs it to be. So the skin protects underlying tissues from a lot of different injuries, and we're talking about temperature extremes and UV radiation or ultraviolet radiation, mechanical forces, toxic chemicals, even invading microorganisms. Now within that skin, temperature regulation is a big thing. So the skin aids in regulating the body temp by preventing heat loss when core body temperature falls. It also causes heat loss, causing heat loss when the core temperature rises, and then secreting sweat to the skin surface where its evaporation helps reduce the body temp. It also works with water retention, so the skin prevents excessive water loss from the body and helps avoid drying of those tissues. And then it acts as a sensory organ with receptors that mediate changes in temperature, pain sensation, body position, responses to pressure, pain, and pleasure stimuli. Then of course we have that inflammatory response as well within the skin. So the skin responds to injuries and wounds with inflammation. That causes that redness that we might see, or increased warmth, pain, swelling, all of those things. And that involves those blood vessels dilating, and it allows those fluids to leak into the damaged tissues to start that healing process. So once again, we're still hitting this A&P review. So patients with significant skin damage, they can become vulnerable to a couple of different things, or several, I guess. Bacterial invasion, so that compromised skin rather, can allow bacteria to enter, increasing the risk of infection. And then there's temperature instability. So the loss of skin can impair the body's ability to regulate temperature, leading to hypothermia or hyperthermia. And then there's fluid balance disturbances. So damage to the skin can disrupt the integrity of the barrier, and that results in fluid loss and potential dehydration. So the epidermis. So the skin's composed of two main layers. We have the epidermis and we have the dermis. So the epidermis is the outer, just that visible layer of skin, and it consists of 5 layers. So it consists of the stratum corneum, so outermost layer made of hardened non-living cells. So those cells shed through a process known as desquamation. I probably just butchered that word for you science people. But then you have these inner layers, so those 4 inner layers of living cells that divide to produce cells for the stratum corneum, and they contain a variable number of cells called melanocytes, which contain melanin granules. So, the darkness of the skin directly related to the amount of melanin present. Now, cells in that stratum corneum are constantly shed and replaced by new cells that migrate upward through the layers of the epidermis. Then we have the dermis, so that's that tough, tough, highly elastic layer of connective tissue, but beneath the epidermis. And then the dermis, it contains several specialized structures: nerve endings, blood vessels, sweat glands, hair follicles, sebaceous glands, lots of stuff going on in there. And then we have subcutaneous tissue. So that's can be known as also as a superficial fascia. It's the layer located between the dermis and the underlying muscle and bone. So it's got some functions: insulation, it helps maintain that temp by reducing heat loss, and then protection, so it cushions those underlying structures. And then there's some energy storage, so it stores energy in the form of fat, serving as a reserve for the body. And then deep fascia. So deep fascia is a thick, dense layer of fibrous tissue that's situated below that subcute tissue. So the location of those structures, we see tendons, muscles, bones are located beneath the deep fascia, providing support and organization to those structures. Now we have these tension lines, as you see that's on this slide. So the skin's arranged over body structures in a way that creates tension. Now those tension varies by the body region, and then it occurs in specific patterns known as these tension lines. So static tension develops in these areas with limited movement, so think of like the scalp. That has some really big implications for wounds, nothing necessarily for us, but we're just talking about in general. So lacerations parallel to these tension lines, they tend to remain closed and heal well, but the larger wounds can be pulled open and they require some closure techniques. However, those lacerations that are perpendicular to those tension lines, they are going to require a little bit more work, as well as they have slower healing and then increased scarring as well. So still talking about tension lines, so dynamic tension, it's found over the muscle areas, Now the tension varies according to the muscle contraction and then the subsequent skin movement. And there's some impact of these open injuries because they can interfere with the healing process. And that's due to a couple different things. So we have disruption of the clotting process. So those open wounds can hinder the blood clot formation. Obviously that's essential for healing. And then disruption of the tissue repair cycle. So that injury can interrupt the natural healing processes of the tissue, and which can require some like scar revision surgery and all that. So, some abnormal scars may necessitate scar revision surgery. So closed wounds. Closed wounds, those involve damage to the soft tissue beneath the skin, and they have not broken the epidermis. So kind of some characteristic, just that common example of a closed wound, a contusion, so a bruise, kind of like what you're seeing, which results from trauma that causes bleeding under the skin. So you get some small blood vessel damage. So if small blood vessels are damaged, you start to get that ecchymosis or bruising, which will cover the area, resulting in discoloration without a significant lump. But then there's also some large blood vessel damage. So if large blood vessels are torn, then a hematoma will form, and that appears as a lump with bluish discoloration due to pooled blood beneath the skin. And open wounds. So open wounds are characterized by that disruption in the skin. We see a lot of different things with that. So lots of types: abrasions and lacerations and avulsions, amputations, bites, impaled objects, blast injuries, high pressure injection, lots of things, puncture wounds. So, open wounds are potentially more serious than closed wounds, and that's due to a couple things. So they're vulnerable to infection. So obviously that exposed tissue increases the risk of infection. Then there's a greater potential for serious blood loss. So an open wound can lead to total blood volume loss, posing a critical risk. And then certain types of wounds should always be evaluated by a physician to ensure proper treatment and as well as to prevent complications. Now, crush injuries, that crush syndrome occurs due to a prolonged compression force that impairs muscle metabolism and circulation. So symptoms typically present following the extrication of release of an entrapped limb. Now there is some external damage and there's internal damage as well. So the external damage of the injury may not accurately represent the level of internal damage that's sustained. Grotesque injuries may appear severe, but they may not be the primary injury affecting the patient. So really, in the context of these crush injuries, those soft tissue injuries are almost always considered less important than the injuries incurred beneath the skin, which may include damage to those muscles, nerve, blood vessels, everything underneath. Then we move, after that, we started talking about that crush syndrome. Now we talk about compartment syndrome. So compartment syndrome occurs when the pressure within a muscle compartment, and it increases to dangerous levels, compromising circulation and muscle function. It can be caused by a couple of different things. We have some external or even internal factors. So some external factors, everything from excessive tightness from bandages, improperly applied splints can cause some compression. Casts can also do that. They can lead to increased pressure. But internal factors, so those mechanisms that increase the volume of material within a compartment, those include things like fractures, dislocation, crush injuries, vascular injuries, soft tissue injuries, all of those things. So everything, when we talk about fracture, bone fragments, those obviously can damage blood vessels. Joint dislocations can cause bleeding. Trauma can lead to internal bleeding, obviously. Vascular, so damage to those blood vessels can cause hemorrhage. Soft tissue injury, so damage can lead to swelling and increased pressure. Now, if they have bleeding disorders, that's going to affect those clotting factors that they have, or that they should have, that the body's going to try to help heal it. Without those clotting factors, and they have these bleeding disorders, that can lead to excessive bleeding. And then obviously just fluid leakage or edema, so that accumulation of fluid in the compartment, then that increases the pressure of this whole injury. And then blast injuries. So there's several different types of injuries from explosions. So those kind of include some soft tissue trauma, so lacerations, abrasions, contusions, due to anything from the blast wave all the way to the debris. Abdominal trauma, so from internal organs can be affected by the shock wave, and then secondary projectiles, obviously. And skeletal trauma, so fractures and other bone injuries caused by blast forces. Blast lung, that's a specific type of lung injury that results from the pressure wave, and that causes some pulmonary damage as well. Now, wound healing, we've covered this several times, but we're going to kind of cover it like maybe we haven't. So maybe you haven't seen any other part or not paid attention. So let's just get into it. So hemostasis is kind of what we're talking about. Not kind of, it is what we're talking about, the process of wound healing. So, a primary concern in wound healing is just that cessation of bleeding. That involves kind of this collaboration of the vessels, the platelets, the clotting cascade, chemical mediators, platelet activation, all of that. Let's talk about that for a second. So those vessels constrict to reduce the blood flow in this process when we're talking about soft tissue injury. The platelets are extremely important because they play a crucial role in forming that clot. And then you have this clotting cascade. So just kind of this series of biomechanical reactions that leads to clot formation. Now, soft injury tissue causes the release of chemical mediators that constrict blood vessels, and that constriction leaves the space for blood to flow, aiding in reducing blood loss. And then we talking about the platelet activation. So platelets are activated by the release of these chemical mediators. They adhere to that affected area and to each other, and they start forming that platelet plug. So that plug temporarily stops blood loss, and it marks the beginning of a blood clot formation. So within inflammation, so following that hemostasis that we just talked about, additional cells will enter the damaged area to facilitate repair, and we start seeing the white blood cells. They start to migrate to that injury site to combat, any pathogens that may have entered the body. And then we see some chemical signals. So chemicals and proteins known as chemotatic factors are released to signal repairing cells to the injured area. So we see granulocytes and macrophages engulf bacteria through that phagocytosis. Now, lymphocytes, they also play a role in destroying bacteria and pathogens. And then we see mast cells. They start to release histamine during the early stages of inflammation. So this release causes the blood vessel dilation. And it also makes those capillaries more permeable, which allows more immune cells to access the injury site. So we're still talking about inflammation. So this phase, this inflammation phase, this leads to that removal of foreign material, so any debris or particles that entered the wound, as well as damaged cellular parts, so dead or injured cells that need to be cleared for healing. And then it also works on those invading microorganisms. So those pathogens that could cause infection, they're also eliminated by the immune response. And then we get into the next piece. So this is deeper than that blood clot formation piece. I mean, we're getting into wound healing and how all this happens, but we start to see this new layer of epithelial cells. It's moved to the outer layer of skin to replace lost tissue, and that's due to that injury. And then we have cell proliferation. So cells in that stratum, going to butcher another word, but germinativum, whatever, multiply, and they migrate across the edges of that wound. So except for clean incisions, that restructured area seldom returns to its pre-injured state. But we do see some new blood vessels form as the body attempts to supply oxygen and then nutrients to that injured tissue. So we see some new capillaries start to develop from intact capillaries adjacent to the damaged skin. But because these new capillaries are delicate, they can bleed from minor injuries. So it may take weeks or even months for those new capillaries to stabilize and become as resilient as the original one. And then we get into some collagen synthesis. So collagen, that tough fibrous protein that's found in scar tissue, it's also found in hair and bones and connective tissue. So that repair unit is synthesized by fibroblasts, which are crucial for tissue repair. So collagen provides stability to that damaged tissue and then helps to join wound borders, effectively closing open tissues. Now, what collagen does aid in healing, it can't restore damaged tissue to its original strength. And then some alterations of wound healing. So wound healing doesn't always follow the expected patterns due to various factors like infection, abnormal scarring, excessive bleeding. Like I said, excessive bleeding can definitely impair the healing process. Slow healing, that's just some delayed healing. And then there's even some meds that can delay the healing process. So corticosteroids or NSAIDs, penicillin. There's a whole host of things that can that can cause that. And then we get into some things like severe alcoholism, advanced age, so diabetes, hypoxia, anemia, lots of things that start to affect that, those alterations of wound healing. So the body areas with repeated motion, so think like maybe fingers or something like that, they tend to heal more slowly. So the positioning of that open wound relative to those skin tension lines, they significantly affect both wound healing and scarring. Now there are some high-risk wounds. You see listed human and animal bites. So they carry a high risk of infection. Also embedded microorganisms. So they can be trapped in injuries caused by foreign bodies or organic matter. And then foreign bodies, so if the foreign body is present during evaluation, it should generally remain in place. Removing the object could lead to some increased bleeding. So we don't want to remove an impaled object unless it obstructs the airway or if it interferes with our chest compressions. Now there are some other high-risk wounds. So when we think of that, we hopefully think of some injection wounds or crush wounds, obviously wounds in the immunocompromised patients, and then even injuries in patients with poor peripheral circulation. So healing, we're talking about immunocompromised patients, is going to be significantly impaired due to weakened immune receptors. Those crush wounds, they often involve extensive tissue damage as well. So abnormal scar formation. So this can occur when the building up and then the breaking down phases of healing are not properly balanced. That leads to a couple things, and we see hypertrophic scars. So they occur in areas under high tissue stress. So think about elbows, knees. The scar does not extend beyond the wound margin borders. More common in individuals with lightly pigmented skin. And then we have keloid scars. So they tend to develop in individuals with darkly pigmented skin. So those scars grow over the wound margins and can become larger than the original wound area. Some of those common areas are ears, upper extremities, lower abdomen, even the sternum. Pressure injuries. So when we say pressure injuries, we've got a couple different things. So that patient is bedridden is one. So prolonged pressure is applied to maybe an unresponsive or immobilized patient. There's some oxygen deprivation there. So those involved tissues become deprived of oxygen. And that's just due to that sustained pressure. So, prevention strategies, obviously, just getting people moving around and not laying on the same spot and all of that. So wounds may need closure. They include open injuries, gaping wounds, so wounds that don't close naturally and are over tension lines, degloving injuries, so these require thorough irrigation and debridement before closure. Ring injuries, injuries that are caused by rings or similar objects, they may constrict the tissue. And then skin tears, because it's tearing those different skin layers. And we're still talking about alterations. So wounds requiring closure, open injuries generally should be closed within 24 hours. Assessment for foreign material, checks for any foreign objects in the wound. Irrigation, obviously we want to clean the wound. And then types of wound closure, we have primary, secondary. So primary wound margins are brought together as the primary treatment. And then secondary, those high-risk wounds are dressed to heal from the inside out. And then there's some delayed primary closure. So delayed closure of wounds that initially undergo secondary interventions. Now there is a risk of infection. So any break in the skin surface can potentially lead to infection. So those larger and deeper penetrations, they carry a higher risk for that infection, which can result in a longer healing time. So the healing process may be significantly delayed. And then there's also an increased risk of systemic infection or other complications. And then once those pathogens, if they reach the body, talking about pathogen activity, they begin to grow and multiply as well. So still talking about some infection stuff. So common signs of infection, some common indicators. So we get some redness around the wound area. We might see some pus, some warmth, some edema. Obviously might be a little bit discomfort for them. So pain or tenderness in the area. And then there could be some red streaks. So those streaks may indicate inflammation of the lymph channels. And then systemic signs of serious infection. So more serious infections can lead to systemic signs, and they might include fever, so an elevated body temp, that can indicate infection. Shaking, so possible possible chills or shivering due to fever, and then joint pain as well. Patient assessment. So remember, we mentioned it before, but skin trauma, rarely immediately life-threatening, but a thorough assessment really is essential. So, we want to focus that assessment process to identify those threats to us and our crew, so ensure the safety of the medical team before approaching the patient. And then we want to evaluate those threats for the patient's condition to determine any immediate risks or even complications that are related to that trauma. Now, address safety first, so scene safe for us, scene safe for the crew, evaluate our mechanism of injury. Now, if a significant MOI is suspected, then we want to maintain a high index of suspicion, even if external injuries appear minor. So consider that force that's involved to assess the likelihood of the internal damage. And then we, once again, make sure that we're protecting ourselves. Then a primary survey. So we want to quickly assess the patient's overall condition and the responsiveness, determine any life threats. That could include altered LOC, so check for our responsiveness, lack of airway protection, lack of patency, so ensure the airway is clear and secure, inadequate breathing, uncontrolled bleeding, and then we mentioned it with that significant MOI also. So we want to consider the impact of that MOI on potential injuries, significant mechanism of injury. And then note external bleeding. So assess for any visible external bleeding before proceeding with the further evaluation. Now remember, we've made that little change, that XABCDE. So we want to look for exsanguination. So really nothing different as I've mentioned in the past, because we're looking for immediate life threats anyways, and that bleeding falls in with that. So we want to determine our mental status, so AVPU. Then we look in for our airway, make sure there's no obstructions, make sure it's open and clear, the patient's breathing. So we want to evaluate the rate, the depth, the quality of respirations. Circulatory status, so palpate a pulse. We want to check our skin signs. We're looking for color, temp, moisture. If no pulse is present, well, initiate resuscitation measures immediately. Now, pale or ashen skin, that indicates some inadequate perfusion. So, cool, moist skin could be an early indicator of shock. So we want to make sure we're paying attention to that. And then we want to make sure we ensure adequate exposure. So we want to expose the patient to assess those injuries thoroughly, as well as in the event that there was a crime involved, I want to make sure that we're preserving that clothing as evidence if you're able to. So you want to cut around rather than through maybe a knife or a bullet hole to maintain potential evidence. and then control severe hemorrhage. So maybe that might take a tourniquet as a priority over other interventions in cases of severe bleeding. So that just kind of gives you an idea. Entrance and exit wound, you may or may not be able to tell the difference. And in my opinion, you probably, for us to try to determine that in our documentation, if you get called into court on it, it may not work out so pretty good if you talk about entrance and exit, although it makes a lot of sense that, you know, the back would be a lot larger and blown out versus the front, secondary to that kind of cavitation. However, you know, you follow your local protocols and your documentation standards. But then we get into our transportation. We want to make sure that we make our transport decision, and then get that baseline vital signs, also our sample history. And then history taking. So we want to gather information about the injury, ask the patient, maybe family members, bystanders, depending on what happened, about those events that led up to that injury, because we want to get some context about it. Medication history. So conduct a thorough exam, perform this assessment. When we're talking about this assessment being our secondary assessment, we want to perform that en route. If there's a significant mechanism of injury, there's adequate time for assessment, or if the patient's in a stable condition. So this kind of speaks to that stay and play versus load and go. So, you know, when someone's critical, or when you think sick versus not sick, if they're sick, we need to get them moving, not staying on scene to do secondary assessments. Obviously, with these patients, especially when we're talking about critical ones, we want to conduct regular assessments en route to the hospital, and we're looking for those changes in the patient's condition, vital signs evaluations. We want to check our interventions. So maybe we use some fluid, maybe we use TXA, whatever. We want to check for, has anything worked well? You know, obviously, you want to document all of that. You also want to include your relevant scene findings. And then when we're talking about this documentation, want to make sure that we describe the wounds in detail, including the size, the location, the depth, any associated complications, so anything that's related to the injury. So maybe there's damage to the underlying structures, or maybe infection because it was an area that was already had infection. You know, as we mentioned, you want to record the interventions performed. You also want to make sure that you record what happened after your intervention. So we want to, you know, our patient's response to therapy basically is what we're saying. So minimize bleeding and swelling. You know, there's that whole basic RICE thing. So rest, ice, compress, elevation, and then splinting. So RICEs. That's obviously not talking about someone that is critical in nature. However, an ice pack's not a bad idea on somebody that is, you know, we're starting to help with that, get rid of some swelling and some pain. So, you know, within blood accumulation, that swelling may occur due to blood from a developing hematoma. You can see some swelling can also result from fluid buildup in the tissue. So we want to use ice as early as possible to help decrease swelling and accelerate healing. So that's kind of a 20-minute on, 20-minute off thing. We want to make sure that we're avoiding tissue damage. We want to maximize our effectiveness also with that treatment. Remember, a lot of times I relate these to really big traumas. However, when we're talking about these things, hopefully you recognize that not everything we're talking about is big traumas. But we want to control bleeding, so we want to utilize the most effective method available to stop bleeding. So prioritizing those techniques based on the severity and then the location of the wound, and then maintain some cleanliness. So keep the wound as clean as possible to prevent infection, promote healing as well. So bandaging and dressing wounds, you want to make sure that we protect the wound from external contaminants. When we say cover the wound, control the bleeding, so help manage and reduce that bleeding. Limit motion, so we want to stabilize that injured area to prevent any additional damage. And then dressing and bandaging, you know, secure the bandage in place, all these basic kind of things. Now there can be some complications, so improper application of those dressings and bandages, they can lead to significant complications, including infection, delayed healing. Earlier we talked about building up that pressure underneath there. Sterile technique, in the event, hopefully we can use some sterile technique, use our most sterile technique possible to minimize the risk of contamination. And then irrigate open wounds with normal saline, sterile water, apply a sterile dressing over the wound site, and then wrap the bandage neatly over the dressing to secure it in place. Now, hemodynamic complications, they may include continued bleeding. So everything with what we've been talking about, maybe it's from some fluid that you pushed, maybe it's just whatever movement, but there can be some continued bleeding from a couple of different things. So, that disruption of clot formation. So, removing an in-place dressing can risk disrupting any clot that's formed. Management of extremity wounds. So if a wound on an extremity continues to bleed, then we might think about hemostatic dressing. That's in the event that you have that. But remember, that's designed to promote that rapid clotting. A tourniquet, that's a last resort to control severe bleeding. And then we also want to make sure that we're conducting our regular assessments to monitor unchecked blood loss and prevent complications as well. So structural elements can be damaged if dressings are applied too tightly. We just kind of mentioned that. So regularly assess and readjust those dressings and bandages as necessary to ensure they're not constricting the tissue. And then when dressings are applied to extremities, we also want to make sure we're looking for pulses, motor function, sensation. Sometimes you might call it PMS, sometimes it might be CMS for circulation, motor sensation. And just to review, so we've got lots of types of bleeding. So we've got that capillary bleeding, so characterized by a slow, even flow of bright, or it can be dark red, typically more darker red, but it's associated with minor injuries. Venous bleeding, generally slow and steady, so it's darker in color because it's deoxygenated. And then ulterior, it occurs in spurts with bright red blood, so this type of bleeding is usually more severe as well as requires immediate attention. Now, when we say some of those large open wounds, it can be a combination of bleeding types. So they often present a combination of both arterial and venous bleeding, and then that obviously starts to kind of complicate the management of that patient. So direct pressure, as we're talking about some control of external bleeding. So direct pressure helps to allow platelets to seal the vascular walls, promoting clot formation. So if possible, use a dry sterile dressing to apply pressure directly to the wound. And it's important to make sure that we're limiting motion. So movement of the injured extremity can disrupt the clotting process. It can also tear additional blood vessels. So just make sure or at least attempt to limit movement of that injured area. And tourniquets, so these are particularly useful in certain situations. So if you have a severely bleeding extremity injury below the axilla or the groin, if other bleeding control methods have proven ineffective also. So some tourniquets designed to be applied with just one hand, facilitating easier use in emergencies. And I always talk about it here in class and school. Considering the world that we live in, it's not a bad idea to make sure that you know how to put one on yourself too. So make sure you understand how to put on a tourniquet on yourself, as well as be effective at it. Hopefully those words will never come true, but always better to be prepared. So hemostatic agents, they can be utilized alongside direct pressure. So when direct pressure alone is ineffective, and really in particular situations such as like some massive chest injuries or when tourniquet placement is impossible. So those dressings are impregnated with agents designed to facilitate the coagulation process that promotes faster clotting. Now make sure, if that's what you're doing, to remove all those other dressings, or it's not going to be so effective, before you apply a hemostatic dressing. That will help to ensure your effectiveness. There it is. your favorite slide. So stay tuned for part 2.